Early days, it was a massive challenge. We were a brand new organisation with nobody in it to start with. There was myself, Dr. Atherton, and a secretary, and that was the start of the CCG. And then we needed to recruit, obviously, when the GPs had voted to be a CCG in their own right. And we were working alongside a CSU that was also becoming a new organisation, and it was sort of this embryonic thing. So it was really challenging times.
In the early days of the CCG, we immediately after the authorisation process, we took stock of where we were. We took note of the fact that it had been commented that we had a fairly low profile as an organisation, and also as leaders. We were not immediately obvious to our main stakeholders, and particularly our acute provider. So we made the decision that we would engage an external organisation development consultancy, and we drew up with their help the organisation development plan.
Well, one of the first things that we did was to look at the context we were in and what challenges we faced and aspirations we had, and what resources we had to deploy to address that. And the conclusion we came to was we needed to get to be really good really quickly. So the diagnostic process really entailed looking at what were the challenges in the system. We were performing poorly in elective and non-elective care, and there were significant financial challenges. And of course, we're not a large CCG, so we didn't have many people or money to put at that situation.
Things were very difficult when the CCG was first forming. There had been probably a difficult relationship between ourselves and the newly forming CSU, and I think that was partly because we didn't have any relationship with the people who worked there.
But as we were developing this organisation, it became sort of blindingly apparent that we couldn't do this on our own. So suddenly our OD plan was actually wiped out, and we just put it to one side and said, well, let's start again. Got an organisation in to help us, and it was very much built from bottom up with staff. And almost from the very beginning of this sort of rebirth of our OD, we included the commissioning support unit, and that has made such a huge difference to how we've travelled forwards.
When we sat down jointly together, one of the frustrations that we have is the absolute deluge of emails and communication, and we very easily decided that we wouldn't send an email and we'd invest more of our time in actually communicating with each other verbally, either by telephone or actually going up to each other and having a conversation to try and relay as much of the information as possible. And I think that really did start to break down barriers in terms of we got to know each other and understand each other.
We identified that really there's three key players in the core relationship. So there's the clinical leadership, there's what we call the professional managers of the CCG, and then there's the professional management of the CSU. And what we've done is some joint development together to say, in order to make things happen for patients around here, what do each of those key players bring to the CCG's work, and what do each of them need of the other? So we've done some explicit work together in groups about what do we as a group offer to the others, and what do we need from the others, and we've done that as a structured exercise.
We got a lot of value for something called the Voice of the Customer exercise, which was effectively going around to each CCG, meeting with the key players in the CCG, and asking them what they expected of the CSU, how they would want the CSU to work, how they would want the CSU to behave and relate to the CCG. But crucially as well, asked a difficult question, which was, what would it take for you not to want to work with the CSU?
One of the first things that we did was to work with our embedded CSU staff on looking at our Myers-Briggs and learning styles and how we work together, which has been really, really helpful in us trying to understand each other and gain a clarity around the expectations that we would have of each other in our role and function.
As part of our striving towards better communication with our stakeholders and also the providers, we organised what we called a GP consultant event, and this was deliberately advertised as an event without any management input, and we believe this was an extremely successful event.
One of the biggest things that came out of our OD together was talking to each other and having a mutual understanding of what it is we want. And one of the rules that we then decided amongst ourselves that we would create was that we wouldn't move forward on any commissioning matter until we understood that we had a mutual understanding. So, I've told you this, you tell me what you've heard.
I went to some events and some of them were held in the evening. And I was also encouraged to do some coaching. I actually only went to 2 coaching sessions as such, which in 6 months isn't a big time commitment. But it did stimulate me enough to think more about the role, what it involved, what it could involve, and maybe the potentials of the role.
The Myers-Briggs training allowed us to sort of understand how each colleague works best. Some are introverts, some are extroverts. And from now on, in ways of working, if we know that a fellow colleague is introvert, we allow them space and time to sort of prepare things and become accustomed to the way we're going to do things.
We've used the GROW model to create groups which we've made sure include CCG and CSU staff together, which we use to problem solve. And we've also used those almost like mentoring groups, so that we've got really strong relationships and we see each other now as teammates.
One other thing that's been really, really useful is having a joint value statement, and that was a statement that was created between the 2 organisations, and it was following a series of OD events, not just one development day, and the speed dating event, where we actually came to basically we've got sort of 6 things that we've agreed that we will do together, and those are our joint values. And when I say we're built on a mutual understanding, we have those pinned on our wall.
Since authorisation, the change in our governing body GP execs that I have noticed is that they've moved from being GPs that consider themselves to be advisors. They've now moved to GPs that are fully engaged and integrated into our clinical commissioning group.
I think the benefits of the scheme have been that the events I have gone to have certainly been enjoyable. There have been occasions where I have met different people. For instance, it's not often you meet the public health consultant who's on the board. Just getting to know different members of the CCG itself, because it does help if you know who to go to if you've got a problem or if you want to develop an idea or things like that. So the networking, which again a word I don't particularly like, but it does pay dividends, I think.
Where we were 18 months ago to where we are today, I would say that the improvement has clearly been the fact that the team works together so well, and there is a clear, palpable view here, evidence of one team. It was never bad before, but it was never quite so joined up and never quite so integrated as it is today.
You can really see the difference from where we were last year and years before. The development that's gone on here now means that we work far better together on all sorts of projects, even with the clinical leaders as well.
I think it broke down a lot of barriers around our communication because we all understood how each other goes about our work and the projects that we're doing.
When I arrived here, what I found was a very committed and enthusiastic group of people that were, assembling themselves to form the new CCG. And I think where we've managed to move to in the course of a year is a very kind of purposeful and cohesive and coherent team of individuals that are getting things done.